In this lecture, I'll recap the definition of health and talk about how we're going to be using it in this course. I'll talk about how the concepts of mortality, health determinants, and health disparities are used in conversations about health systems. I'll present some examples of these conversations, and the objective of this presentation is not to give you a set of bulleted definitions. I hope you refer to your book for that, if I use terms you don't know. Instead, I hope to give you a sense for how those definitions have been used and are being used to construct our current health system. We're going to talk a little bit about the relationship between these health determinants and health systems. We'll also talk about ecological models of health, images that can help us think about the complexity of health problems and how to approach solutions. I think that's important because it gives you a sense for where you fit in that system as a health practitioner. You're more likely to be conscientious about how you fulfill your role if you know how it fits into the bigger system. Even more important is that this is an ongoing conversation, and I really want you to be a part of it. The more people we have contributing to the conversation about health, the more humane our health systems will be. So let's start by sort of deconstructing our definition of health. Health is an abstract tool. It's an idea, right? A concept that we use to help us communicate, to make sense of things that seem to exist in or happen in our environment. Health is not a stone. It's something that people are constantly defining and redefining because our preferences change and because new things seem to come up in the environment. Plus, everybody has a different perspective on the world. They occupy a unique space and have unique taste. And what's important for this class, everyone has a different idea about what constitutes health and pain and all that. That's why Dr. Udi says there's as many definitions of health as there are people in the world. So health is hard to nail down, but that's okay because if we and our environment are always changing, we don't want a definition of health that can't change with us, right? We want a definition that's useful. We want a tool that can help us communicate in and about our environment that's changing all the time. So it's important that you learn the language we use to talk about health more than it is important for you to learn the definition of health. I think that's why the World Health Organization backed away from a more simplistic definition, that absence of disease definition, and took on a broader definition that you heard in the last lecture and that you see here. So if we start with this definition, then it seems a health system has to consider a broad range of factors that affect health. We call these health determinants. But before we go on, let's talk a little bit about mortality, death. If we're going to have a good talk about health systems, if we're going to talk about how to organize systems around health and do something about it, then we have to think about some of the basic assumptions that we make. Most of our health system is organized around the idea that health equals not dead, or at least that a necessary criterion for health is that you be alive. You can't really be healthy if you're dead, right? Now, most of us would call that true, but nothing in healthcare, even whether living is better than dying, is quite that simple, right? Remember, that's why we came to such a broad and flexible definition of health. Well, our healthcare system still prioritizes the creation of and allocation of resources around the prevention of death. Mortality is very often presented as a rationale for selecting research topics, making budget decisions, and other kinds of organizing around health. Here's a little clip that demonstrates the way health professionals use the concept of death and longevity. And I also want you to note the way wealth and life expectancy are used. Pay attention to the assumptions this guy makes and what are some of the implications of the data that he shares here. Also look at the x-axis of his chart. Anybody got a problem with that? But anyway, it's a pretty good clip, so let's watch that.
So, here we go. First, an axis for health. Life expectancy, from 25 years to 75 years. And down here, an axis for wealth. Income per person, $400, $4,000, and $40,000. So, down here is poor and sick, and up here is rich and healthy. Now, I'm going to show you the world 200 years ago, in 1810. Here come all the countries. Europe brown, Asia red, Middle East green, Africa south of Sahara blue, and the Americas yellow. And the size of the country bubbles show the size of the population. And in 1810, it was pretty crowded down there, wasn't it? All countries were sick and poor. Life expectancy were below 40 in all countries. And only UK and the Netherlands were slightly better off, but not much. And now, why start the world? The Industrial Revolution makes countries in Europe and elsewhere move away from the rest. But the colonized countries in Asia and Africa, they are stuck down there. And eventually, the Western countries get healthier and healthier. And now we slow down to show the impact of the First World War and the Spanish flu epidemic. What a catastrophe. And now I speed up through the 1920s and the 1930s. And in spite of the Great Depression, Western countries forge on towards greater wealth and health. Japan and some others try to follow, but most countries stay down here. Now, after the tragedies of the Second World War, we stop a bit to look at the world in 1948. 1948 was a great year. The war was over, Sweden topped the medal table at the Winter Olympics, and I was born. But the differences between the countries of the world was wider than ever. The United States was in the front, Japan was catching up. Brazil was way behind, Iran was getting a little richer from oil, but still had short lives. And the Asian giants, China, India, Pakistan, Bangladesh and Indonesia, they were still poor and sick down here. But look what is about to happen. Here we go again. In my lifetime, former colonies gained independence, and then finally they started to get healthier and healthier and healthier. And in the 1970s, then countries in Asia and Latin America started to catch up with the Western countries. They became the emerging economies. Some in Africa follows. Some Africans were stuck in civil war and others hit by HIV. And now we can see the world today in the most up-to-date statistics. Most people today live in the middle, but there are huge differences at the same time between the best of countries and the worst of countries. And there are also huge inequalities within countries. These bubbles show country averages, but I can split them. Take China, I can split it into provinces. There goes Shanghai. It has the same wealth and health as Italy today. And there is the poor inland province Guizhou. It is like Pakistan. And if I split it further, the rural parts are like Ghana in Africa.
And yet, despite the enormous disparities today, we have seen 200 years of remarkable progress. That huge historical gap between the West and the rest is now closing. We have become an entirely new converging world. And I see a clear trend into the future. With aid, trade, green technology and peace, it's fully possible that everyone can make it to the healthy, wealthy corner.
Well, what you have seen in the last few minutes is a story of 200 countries shown over 200 years and beyond. It involved plotting of 120,000 numbers. Pretty neat, huh?
So mortality, including infant mortality, is considered by many people in public health to be a leading indicator of the health of a population. Well, why is that? And how does that affect the way we organize our health systems? But we'll talk more about that in a minute. For now, the point is that to have much of a dialogue about our current health system, you need to know some of the language around mortality and mortality statistics. Here's a list of the top 10 causes of death according to the Center for Disease Control and Prevention. Notice that these data are age-adjusted. That's an important concept. When, why, and how to adjust data for age and other factors is something you can be tested on, not only in this class, but in most any other public health course that you're going to take. Hit me up on the discussion board if you need help with it, but check the book out, see if you can't come up with that. Now back to this causes of death. Our definition of health implies that no matter what aspect of health you care about, what disease or condition you're going to study or work on, it's important to understand how it fits in the context. That is, you have to understand it as it relates to all of the factors that are associated with it. It's a pretty overwhelming way to think about a health problem, so we use pictures and models. Ecological models are pictures people use to help communicate about how this broad range of personal, social, economic, and environmental and other factors seem to be related to each other and to what we think health is. A couple of these models are presented in your book, and you don't have to learn these models in the sense that you have to memorize them. You only have to memorize a model if you're going to base a paper on it, frame a project around it, or be tested on it, I guess. The bigger point, though, is that people who spend most of their time talking about health, these health experts, seem to think that health is affected by a lot of different factors on different levels and in very complex and interrelated ways. On page 54 and 55 of your book, you should read the section called Contemporary Models of Health Determinants. What I take away from this section is that everything is the most important thing in health. And that's probably true in a way, but how does that help me as a health professional? Well, here's a couple of short clips about how the ecological model or the ecological perspective emerged and how it can help us think about a particular health problem.
Okay, so there are these pathogens that are floating around in our environment. We touch a contaminated surface, or somebody coughs in our face, and we're the host. The pathogen invades the host, and then we break out with some kind of illness symptom. So this is the germ theory as developed by Louis Pasteur and Joseph Lister. It's all explained in terms of biological factors. Now, there's some interesting research that began to develop in the social and behavioral sciences that question, well, if people are under stress, does that somehow compromise their immune systems? Sheldon Cohen, Tyrell, and Smith at Carnegie Mellon decided to test the notion that psychological stress might be a moderator of people's reactions to microbes or pathogens. And what they found is that psychological stress was having a kind of moderating effect on the germ theory. And what Cohen did in his study of psychological stress and colds is that he creatively combined these different kinds of facts: biological, psychological, social. He didn't have a lot on the physical environment in that particular study, but he was mixing across these different levels of analysis and facts. What I'd like to do now is move into what do we mean by the ecological paradigm. We're going to start with some major assumptions and features of ecological research. The units of analysis are systems in themselves. So all units of ecological analysis have that systems quality. And then there's the idea of homeostasis or equilibrium, that people and environments try to achieve a kind of equilibrium with their surroundings. And there are also, in addition to these conceptual ideas, there are methods and metrics that social ecologists tend to use, or ecologists of any stripe for that matter. Generally, there's an emphasis on aggregates or populations and the macro level of analysis. As I mentioned, a lot of these ideas started in the biological fields in terms of looking at these biomes, combinations of plant and animal species, and very much an emphasis on natural environments, and not so much with people involved, but rather looking at non-human species in much of the early ecological biology research. And we know that people create a lot of impacts on their natural environments. And some of these examples are from China, where the Yangtze River has been dammed for a variety of reasons. One, to create hydroelectric power, another to control flooding. So certain species are becoming extinct because of the damming of the river. Mudslides have occurred which have impacted settlements near the river. More than 1 million people have had to be relocated into basically new high-rise towns higher up, because as the riverbank becomes dammed, people have to move upwards. So there have been a number of consequences to how this intervention for a lot of positive purposes, to generate energy and to control flooding, has led to certain negative consequences.
I'm Stephen Taplin from the National Cancer Institute. I was a family doc for 20 years in the Northwest. These are all ways that are out there in the literature that talk about multi-level interventions. We have chosen a biopsychosocial model developed by a person from Rochester, New York, which is where I trained as a family doc. That is George Engel. He looks at individuals, groups, organizations, communities in the nation, really looking at the aggregates of individuals as, for me, for us, as potential targets of interventions. And so really, look, we take that model as our model. The layered context of care is what we call it. We also call it the onion. We expect that if we address factors in those layers, we can affect quality and we can affect outcomes. But it's also clear that this is a cross-sectional view, and that outcomes and care is not a single event. That in cancer, care is a continuum. That there are a number of types of care, from looking at people at risk in the population to thinking about primary prevention, so changing diet, changing physical activity, thinking about detection or diagnosis. And each of these types of care needs to be addressed in order to move somebody all the way across the cancer continuum. So there is a time element, there is a longitudinal element. But there's also an element, and a fact that I think any practitioner in the audience knows, that it's the connection between the steps as much as the steps that matters. And if you're in the middle of the care process, it's how you link people up and link organizations and link the steps that actually makes it possible to traverse that entire continuum. So we think also about the transitions in care, and it's the transitions and the types of care, it's those two pieces together that address the quality measures that we all know so well from the IOM. And that those quality measures then affect patient outcomes, and we can look at patient outcomes at the individual level, their biologic outcomes, their quality of life, or we can look at the population level, the summary across all the individuals, to look at mortality, or look at morbidity, or look at cost effectiveness. So it's a way of thinking about care as a longitudinal rather than a single event, as a longitudinal rather than a dyadic discussion between a doc and a patient, but as a process overall. And that's a critical step in understanding, we think, and I think, in understanding the process of care and understanding the potential influence of these multiple layers on that process of care. And then when you string out that process of care, you begin to think that, in fact, it is a long series of events, and as a person enters that, they are then affected by family and social support all the way across that continuum. They are affected by providers, a set of providers, all the way across that continuum. They are affected by the organizations all the way across that continuum. And they are affected by the communities in which they live and communities in which that care occurs all the way across the continuum. But, of course, it's not that simple. In fact, if you look at it, there's reason to believe that the effects are different at different points in the continuum. So family and social support may be very important at the beginning, and providers may play less of a role. But as you move into the detection and diagnosis and treatment part, providers become a bigger factor. They are more important to actually what happens. And family are still there, but may play a lesser role. And if you get to the end, it may jump back. Families and social support may vary again and become higher. So that the factors are not monotonic. They are varying across the continuum. And we haven't even thought about organizations and communities, which also are going to affect and going to change their influences across care. And how do these levels affect each other? It's another critical question. And I think it's one of the questions, at least as I started to read the literature, where I got a little bit confused between what's a level and what's a mechanism of influence. And so our structure, is policy a level? And there are papers out there that use policy as a level, or is policy just a way of one level affecting another? That in fact policy can be at a national level, can be at a state level, could be at the community level, could be in a team. They can set policy. So I tried to separate out the factors that are levels, human sets of aggregation, and factors that are ways that those levels influence each other, and think about structure, policy, incentives, interpersonal interaction to affect people. Those are all mechanisms and potential ways that you would organize an intervention. So care occurs in context, and it's a complicated context, and we need to think about it.
So everything is the most important thing. Doesn't seem to be much help at first, but it seems important to understand that isolating and intervening on one of the intricately related factors in the model is likely to have some unintended effects on the rest of the factors. To illustrate that, let's talk about mortality again. Let's do a little thought experiment. I want you to imagine a health system as if it's one system and it was set up by like-minded people say 100 years ago. And let's say that system was set up on a very narrow definition of health, that health equals absence of death. In other words, the system was designed to decrease mortality and increase longevity, right? Well, if the system works, if it's effective, then we should see longevity increase. The creators of the system would probably gauge the effectiveness of their system by comparing the longevity of their people to the longevity of people in countries with other systems. Like I've often seen this chart used to determine which country has the best health care. That is, they'll say things like, why do we spend more and get less? But the point is, longevity is the outcome of interest. The creators of that system would also expect that the more efficient their system is, the more longevity will increase, right? They would probably gauge the efficiency of the system by comparing the longevity now with the longevity that was in the past. And here's another illustration that's commonly used by those in healthcare to tout the success of our system. Isn't this the kind of outcome we would want from a healthcare system designed to prevent death? It would be a success, right? But again, our ecological model and broader definition of health suggests that if a healthcare system focuses too narrowly on one aspect of this complicated thing we call health, there are bound to be effects on the other aspects. You know, these models are meant to help us think about unintended consequences. And externalities is an important concept in public health. So it's complicated. But one thing's for sure, systems can be arranged to maximize isolated factors that we like, even isolated factors of organisms that we like. That is, we can create systems of breeding dogs to get big ears, no hair, black tongues. Systems that create pigs with huge tenderloins or hams. Or systems that create birds with huge breasts, because those are the features we like. But there seems to be some externalities, right? There are environmental, social, and health consequences of the way we treat those animals, right? We protect them by harm, by putting them in a cage, but then their immune system is compromised. They don't get exercise, so we give them antibiotics, but then resistance develops, and so on. There are other unintended consequences too, like breeds of dogs who have unique disorders or vulnerabilities, like pig meat, I guess that's pork, that has been exposed to steroids, antibiotics, etc. And birds, or any of these organisms really, that are so big or otherwise incapacitated that they're now dependent on that system. So back to our imaginary health system. Think about what a health system would look like if it were designed to prevent death above all else. What would some of the strategies and interventions look like? What would the externalities of a system like that be? So what would the unintended consequences look like? Well, now let's shift to another concept that's important to public health conversations. Health disparities could be considered an unintended consequence of, well, I guess that's for you to think about. Are health disparities a consequence? Are they unintended? Are they inevitable? And so on. We talk about health disparities as a difference in any of these. I'm going to use some data from a talk I put together when I was working in Jefferson County. It's from the county health rankings. Jefferson County was ranked 50th out of 75 Arkansas counties. So to illustrate a health disparity, I'm going to compare characteristics of Jefferson County to those of the highest ranked county in Arkansas, which is here, you see here, my reference county. So at age-adjusted infant mortality rate, you see Jefferson County had 12 deaths per 1,000 live births. Reference county had 7. That's a difference of 5. So we can look at, all these mortality rates, but we don't just have to look at health outcomes, right? We can look at health status. We can look at behavior. So really we can look at any of the health determinants that we've talked about so far in terms of disparities. So it's a pretty simple concept, right? Until you try to explain why it exists or try to do something about it. The book says that our current system of healthcare delivery traces its roots to the traditional beliefs and values espoused by the American people. It'd be kind of fun to see if we, as a small group of people, could come up with a consensus about what that statement even means, much less whether it's true or not. But they're just trying to use it to lead into a discussion about some of the belief systems, theories, that have been dominant in health systems dialogue in recent years. The health system is a social determinant of health, right? The health system you live in has a lot of influence on your health. The book does a pretty good job of comparing and contrasting the perspectives of market justice and social justice, giving some examples of how they sometimes complement each other in our mixed system. So I'm going to leave that reading to you, but these clips are pretty good. It might give you a little more to think on. Now, the way these perspectives are presented in the book, it's easy to get polarized. That is, we seem to want to pick a side. That's the way we get stuff done around here, right? Narrow the solutions down to two opposite alternatives, team up around one or the other, and then try to out-policy process the other team. And then it's sort of winner take all. So is health a right or a privilege, like we saw in that clip, is often used to frame the distinction between market and social justice. Well, I'm presenting these clips not to present both sides of an argument or to let you judge which one you like or which one wins. I'm showing them to you as an example of how we talk about health using the language of markets, justice, social, etc. It's not about deciding which of these perspectives is right. It's about understanding what each of these perspectives can add to our discussion about what we decide is right. And you may think these topics are all over the place, but I don't expect you to take notes on any specific topic. What I want you to do is think about, in all of these situations, think about what are the assumptions, what are the perspectives these speakers are coming from, whether it's market justice, social justice, and what are some of the assumptions that they seem to be making when they state things they think are facts or when they make decisions. So give these a look. Let me know what you think.
Dr. Freeman, concerning your comments, your non-controversial comments that there's no place for government in private medicine, what are your views on the regulatory powers of the FDA and the work that they're trying to do?
Well, you have a great many heart specialists in this room, I think, or some. I think if you ask them, they will tell you that there are some excellent beta blockers which are available in Great Britain, in Canada, and in the rest of the world, which cannot be sold in this country because of FDA regulation. I have seen estimates from reputable physicians that the availability of those beta blockers would save roughly 10,000 lives a year. I believe the FDA, as it has been operating, has done vastly more harm than good. I have no doubt that it has prevented some bad drugs from coming on the market. But in compensation for this, it has also prevented some very good drugs from coming on the market. It has made the cost of discovering and developing new drugs, it has increased it enormously. It has driven medical research out of this country and into other countries. So I think the FDA has been an unmitigated disaster over the past 20 years. Yes, sir.
Dr. Friedman, I'm fascinated by your question or your statement that licensure is something that has been a harmful effect, especially in the area of medicine. I think this probably comes as a bit of a shocker to most of us. What do you answer the particular problem which relates to control, say, of quackery, of inadequately trained individuals who are dealing with situations where vital decisions, of course, don't have the option for the normal, slow process of people getting education, finding out what goes on during that particular period, and how do you worry about that?
Sure, you should worry about that. Let me ask you first a very simple question. How many people do you know who pick their physician by opening the yellow pages, taking all the licensed physicians, taking a pin and sticking it in?
Some, quite a number, I would suspect, might.
No, maybe. I don't know very many of those. My point is that having a license is no assurance of the ability to practice medicine. A man was licensed 30 years ago. He may be thoroughly incompetent now. So licensure is no assurance of quality. In the next place, We have lots of other assurances of quality. The fact that a man may offer himself as a physician doesn't mean that he can misrepresent his training. If I hang out a shingle saying I am a graduate of the Harvard Medical School when I am not, well, then I ought to be sent to jail, and I should be sued for fraud and misrepresentation. So that there's nothing about the absence of licensure that makes it unnecessary for people to be able to demonstrate their capacities. And indeed, you would be more inclined under that kind of a system to look at what an individual's qualifications were. We don't require licensure for lots of skilled professions. We don't require licensure in most states for an architect. Yet very few architects are able to practice successfully without having good training. In the next place, the way in which most of us, and this is why I link this discussion to the Mayo Clinic, the way in which most of us get assurance of quality about anything, it's not because we directly can judge. If I go buy a shirt at the store, I can't judge the quality of a shirt. If I buy an automobile, I can't judge the quality of the automobile. We get our assurance from the middleman, from the department store, which stands in back of the shirt, and which has a strong incentive to provide me with good shirts. From the dealer, who wants to stay in business for a long time selling cars, has an incentive to provide an assurance of quality. People who come to Mayo's get their assurance of quality from the fact that the Mayo Clinic has a very strong incentive to choose able, well-trained physicians. In the absence of licensure and the restriction on entries that accompanied it, you would have had a much greater development of hospital group practice of this kind, which would have provided a very much more effective technique of selection, of quality of medicine. Next, the fact that you have had licensure has made it much more difficult over decades to eliminate low-quality practice. As you know, only in recent years you've had a spate of medical malpractice suits. One of the main reasons why you didn't have many more of them earlier was because the American Medical Association had a concerted policy of making it extremely difficult. Physicians who were willing to testify in such cases found that they lost their hospital credentials. Now you come, why is licensure so essential? Because it is the key to the power of organized medicine. Without it, they would have no power to do harm. They would have lots of power to do good, but no power to do harm. Why is that the key? Because the key to the control of medicine starts with who is admitted to practice. Now, you cannot do it at the stage of licensure itself. If a man has gotten through medical school, if he is interned and so on, it's going to be very hard ultimately to deny him a license. He's going to take the exam over and over again. If you want to control entry, and don't make any mistake about this, the evidence is overwhelming that there was a deliberate policy on the part of the Medical Association in the 1930s to keep down the number of physicians. That policy has changed in recent years for various reasons, but it was a policy for a long time. The most effective way to do it is before people start going into medical schools. And licensure was a key to this because the licensure laws in almost every state, as a result of the pressure of the organized medicine, require that nobody may be licensed who is not a graduate of an approved medical school. And by some strange accident, the list of approved schools in every state is identical with the list of schools approved by the Council on Medical Education and Hospitals of the American Medical Association. And I can go down the line, a long line of them, and you will discover, every time you look at this, that the key element is licensure. Now, moreover, licensure is critical to preventing the unauthorized practice of medicine. You and I know, and many of us know, that there are many medical practices which can perfectly well be carried out by people who do not have the full training. People who are medical technicians. There has been some increasing use of them in recent years. But one of the main factors that has prevented a more effective use of medical technicians, a more effective use of the physicians, has been the definition of what is medical practice and what is unauthorized. You've started me on a subject on which I could go a long time, but perhaps I've said enough to suggest that it isn't quite as simple as it may seem at the outside. That a label of good housekeeping is not the same thing. Yes, ma'am.
Dr. Friedman, you mentioned that 80% of the people in the country are covered by private insurance plans. I'm curious as what your proposal would be to cover those who presently are not covered and those who truly cannot afford at this point because they are below the so-called poverty level, they are not in organized labor, they are not a member of a large corporation which provides such a plan for its employees.
I said before, I do not believe you ought to have any special program for medicine at all.
Yes, I understand.
I believe, I have long been in favor of substituting for our present whole set of welfare arrangements a comprehensive negative income tax, which would provide to individuals below a level a sum of money which would assure that they would be able to maintain a particular level. There is no reason why part of that sum of money cannot be spent on the purchase of the same kind of medical insurance everybody else says. I have long been opposed, and I think you should be opposed, to giving special sums of money for people for housing, and another sum for food, and another sum for clothing, and another sum for medical care. We ought to give people, the problem of poverty is money.
Right, exactly.
And we ought to have a program under which we assure a minimum level of income, of spending, and then let people spend it the way they want.
Absolutely. Good answer. Thank you.
That's kind of funny. That answer seemed to please her a lot. Maybe she was a Confederate in the audience. But there's a hodgepodge of things in there. I'd be interested in what strikes you most about that. So hit me up on the discussion board. And this next one, listen to how this guy talks about sort of a market justice. The video's terrible in this. Just close your eyes and listen to it. But the point is, he's saying that the market can help people.
Well, you know what? I said that half of my life is involved in a humanitarian foundation which is looking to do just that, because one of the things that AIDS does is it creates inequality. AIDS is a disease which spreads through ignorance and through fear, misunderstanding, and broken relationships. It destroys families by removing the breadwinners, so the children grow up very poor. And yet, with my medic hat on, I see that. But with my business hat on, I see something different. And the truth is this, that as you know, economic growth in the last 5 years has lifted more people out of absolute poverty in places like Kolkata or Shanghai or Myanmar or wherever else, lifted more people out of absolute poverty and indeed relative poverty in Eastern Europe, in places like Russia, in Ukraine, and places like that. It's economic growth which is paying the pensioners their pensions after the chaos of the breakup of the Soviet Union. It's not government policy. It's businesses that are generating taxes and wealth. It's capital growth. It's the value of property increasing. So older people are finding that they actually have equity in their homes. They're releasing a bit of that so the next generation can buy their houses. And so the wealth is being spread across the whole community. So the short answer to your question is that actually trade itself, doing the agreements, traveling to countries where there are large labor pools of perhaps relatively unskilled, poorly paid people that can be trained by your organization, invested in a socially responsible way. So we're also educating their children. We're providing some basic health care. It's packages of support. And these things, more than anything, will drive economic growth. As I often say, I'm often criticized in Europe for some of the things I say about outsourcing. And they say, oh, you know, you're destroying the jobs of people in Bristol. And I say, well, I don't think that's true. If you want the world to actually turn more smoothly, then this is a mighty force for good change. Because for every job that is lost in Bristol, every job that is outsourced to Hyderabad, as you know, we create perhaps another 50 to 100 jobs which are somehow going to benefit from that single job. We know that $100 put into the pay packet of someone in Hyderabad gets spent up to 100 times in a month. 3 rupees goes to buy, I don't know, a small number of rupees goes to buy an SMS from a woman who's sitting on the ground with her 3-year-old child. She's selling the SIM card. And you know that within 1 hour, she has taken those rupees and she's spent them in the market to buy rice. And you know, within another 3 hours, the person who's received the money for rice has gone to pay the landlord his rent. And so the money goes spinning round. And we know that one of the real engines that happens in a country like India or Indonesia or Thailand, it comes through the outsourcing, the offshoring, and the rest. And out of this buzz, this entrepreneurial dynamism grows, and more goods and services get bought, and some of it comes back to Western countries as well in terms of increased demand for products and services. So for me, globalization, which sometimes can bring its own problems, but globalization has this capacity, I believe, to produce economic growth which will solve many, many of these social challenges. In the meantime, it's very, very important that as corporations operating globally, that we understand very sensitively the environments that we're in.
Again, whether you believe that guy or not, he seems to believe what he's talking about. This next guy is going to present more of a social justice perspective on the way things are set up.
When I talk to people, especially people that are not in the health sciences, but also some people that are, the answers that I get are things like, well, disparities exist because there are biological differences. So there's some gene that's causing heart disease and cancer and stroke and diabetes and HIV and homicide and injuries, and it also makes you black, right? It's that same gene, right? There's a gene that does all of that, right? But this is the kind of thinking that we often fall into. Or you'll sometimes get, well, it's not really race, it's really socioeconomic status. Right? In which my response is always, well, even if that was true, why would that be any more acceptable? I was in graduate school, and I was working on my dissertation. So I was having one of those days. I'm sure you know what I mean already, right? And I was trying to find something to do other than work on that damn dissertation. And so I decided to take a walk. So I found myself in this used bookstore, and I'm looking for something to read. Anything that does not have a bibliography in it. I mean, I'm open for anything, as long as it wasn't academic. And I come across this book, which I still have on my shelf at home. This is a book about the Titanic. This was before the movie came out, by the way. All right, so I hadn't seen the movie yet, so I'm not that bad. But what's really fascinating, I come to this page where they're talking about these survivors. They're talking about the female survivors, and they're talking about them who survived as a function of the class of ticket that they had, which was stunning to me, right? And so I'm going through this information that they're providing, and I start calculating these rates, which tells you something even more about my mental state at the time. Calculating mortality rates in the clearance section of the used bookstore. Right? I was gone at that point. Clearly, I was going to be a researcher, right? So I've since recalculated them and made sure that they were correct. And these were the rates that I found. That the class of ticket predicted whether or not you survived the sinking of the Titanic. It was fascinating to me. It seemed to me this was a perfect analogy for the U.S. healthcare system. Big, expensive ship, giving out unequal treatment, destined to hit an iceberg and sink. But when you think about why it happened, what happened was it was really about scarcity and resource allocation. There was only enough lifeboat space to accommodate 53% of the souls on board, and when it comes to scarce resources, who you are determines who gets access to what. An even better analogy of the U.S. healthcare system. So now, okay, that was 100 years ago, April 15th, 1911. That could never happen today, right? Well, I promise you I did not Photoshop this, except to write in coach class and first class. This is the U.S. airliner that landed on the Hudson in 2009. And as you can see, the first class cabin has life raft, and the coach passengers are standing on the wing. By the way, the conference organizers, about my return flight back home, anyway, so Now, this is fundamentally what health disparities is about. It's about resource allocation, who gets access to what. Now, the topic of health disparities really came onto the national scene in a big way in 2002, with the publication of the Institute of Medicine's report on equal treatment. Many of you, I'm sure, are familiar with this report. Mainly, it was a report on mortality and morbidity rates. And you saw the bar charts and the huge differences across the different groups. But the response was, well, this is complicated. It's an access to care issue. It's patient preference and patient behavior. It's the broader social environment. It's all of these things, and that's complicated, and that's not really something that we can deal with within the healthcare industry. But what the IOM does with this report that I think was really a stroke of genius was they collected high-quality research that looked at disparities by race or ethnicity among people that had health insurance, had access to care, identified that they had a symptom of some sort, and sought care, got into the system, and actually got seen by somebody. And so once we've taken all of the barriers out of the equation, do we have disparities in quality of care among people that have access? Now, ever since this happens, we've used a social justice frame to raise awareness around the problem and to argue for resources being allocated to the problem. And I think we've done a fairly good job in terms of raising awareness among policymakers, at least. Here's a quote from a prominent national policymaker who says, the key test for any new system is its ability to provide access to quality care for the poorest and sickest among us. And the elimination of health disparities must be a critical goal. No American can be left out.
So you can see how this social justice frame is used in these bigger political discussions. And speaking of that, this next clip is sort of part of the history of our discussion. And although it's kind of old, you got to think about these are the guys who were defining health and defining health care and how we're going to approach it in the last few centuries. And I think that's important as we think about what it's going to be like now and in the future.
This has to do with the Ford Pinto. I'm not sure if you're aware of the recent revelations that have come out about the production of that car. Ford produced it knowing full well that in any rear-end collision, the gas tank would blow up because they had failed to install a $13 plastic block in front of the gas tank. And Ford estimated in an internal memo that that would cost about 200 lives a year. And they estimated further that the cost of each life would be $200,000. They multiplied and they found that the cost of installing those blocks in each of the cars would be more than the cost of saving those 200 lives. And over the past 7 years, the car has been produced and over 1,000 lives have been lost. It seems to me that Ford did what would be the right thing according to your policy, and yet that seems to me to be very wrong.
Well, let me ask you, let's suppose it would have cost $1 billion per person. Should Ford have put them in nonetheless?
But
See,
it wasn't a question of
you know that you're really only arguing about price. You're not arguing about principle. No. Because you cannot, nobody can take the principle. Nobody can accept the principle that an infinite value should be put on an individual life. Because in order to get the money involved, in order to get the resources involved, it's not money. In order to get the resources, they have to come from somewhere. And you want the policy which maximizes the situation overall. You cannot accept a situation that 1 million people should starve in order to provide one person with a car that is completely safe.
That's absolutely right.
Right. And therefore, you're not arguing anything about principle. You're just arguing whether Ford used $200,000 was the right number or not.
No, I'm not arguing
Suppose
that
it were
at all.
$200 million.
No.
Suppose it were $200 million. What should Ford have done?
$200 million for what?
Suppose it would have cost $200 million per life saved. Should Ford still have spent that $200 million?
You mean per...
That's not the question.
That's not really the question.
Yes, it is a question.
Yes,
that's the principle of the question. That's the only principle involved. I don't know whether Ford came to the right answer or not. That's a question of whether these numbers are valid numbers for the relative costs of different things. We're not arguing about a principle. If you once agree with me that if it had been $200 million, the cost per life saved had been $200 million, you would not argue. Look, let me go back for a moment.
Can I say something in response to that? If Ford had not been able to market those cars in the same kind of economic bracket because of the price of installing this one plastic block, that would be a different question. Maybe Ford could have considered redesigning the whole car so as to make it cheaper. But what we're talking about is balancing advantages and balancing principles.
And that's why
Just a minute. I'm a supporter of abortion. Therefore, I don't believe that every single human life is sacred. I believe that principles have to be balanced. And yet I don't see Ford spending $13 less on each car at the cost of 200 lives a year as being a principled position to take, and yet I think your logic requires it.
Suppose it had been one fewer life a year. So that the $13 per car, so that that one life, instead of being 200 times, what's 200 times 200,000, it's 40 million. Suppose it had been one life a year, so that it cost 40 million. Would it have been okay for Ford not to have put in that block?
You can't predict that one life is going to be cost because of a physical defect in the car. This was a clear...
I know, but you're evading the question of principle.
No, I'm not. I'm saying that they knew before they put the car out that there was a mechanical defect.
You know, when you buy a car, you know that your chance of being killed in a Pinto is greater than your chance of being killed in a Mack truck.
No, I didn't. I didn't know that the gas tank would rupture.
Of course it is a question. Well, every one of us separately in this room could, at a cost, reduce his risk of dying tomorrow. You don't have to walk across the street. Of course. The question is he willing to pay for it? And the question here he should be raising, if he wants to raise a question of principle, the principle he should raise is whether Ford wasn't required to attach to this car the statement, we have made this car $13 cheaper, and therefore it is whatever the percent is, it is 1% more risky for you to buy it.
But why?
Now then he would be arguing a real question of principle.
Why should they do that? Doesn't that interfere with the free enterprise system that you're touting?
No.
Why not?
Because the consumer should be free to decide what risk he wants to bear. If you want to pay $13 extra for that, you should be free to do it. If you don't want to pay $13... Excuse me, we have to keep it to the audio over here.
So then the government does have the right to require information of corporations, is that right?
No, the government has a right to provide courts of law in which corporations that deliberately conceal material that is relevant can be sued for fraud and made to pay very heavy expenses. And that is a desirable part of the market, of course. What I'm trying to say to you is that these things are really a little bit more subtle and sophisticated than you are at first led to believe. You can't get easy answers along this line, because your way of putting it really doesn't really get at the fundamental principles involved. The real fundamental principle is that people individually should be free to decide how much they're willing to pay for reducing the chances of their death. Now, people mostly aren't willing to pay very much. I personally regard this as very, very illogical. I see people on all sides of me smoking. Well, there's no doubt, nobody denies that increases their chance of death. I'm not saying they shouldn't be free to smoke, don't misunderstand me. I just think they're fools to do it. And I know they're fools because I quit on the basis of the evidence 18 years ago. But that's the real issue. And if you want to be rate Ford, you ought to be rated on those terms, not on the ground that you don't think they use the right numbers. Now look, I don't think we can keep on going very much. I'm afraid we're going to run out of tape, and I'm afraid I'm going to run out of voice. So I think I'll call it there.
Finally, I want to share with you some of the local discussion, because there's a lot of talk going on right now, and if you really want to be a part of shaping the way healthcare looks in Arkansas over the next few years, you probably want to jump in. Here's a couple of guys who are making decisions about what your healthcare system is going to be like. And I think this is local, so it's really important.
All right, the U.S. Supreme Court ruled on Thursday that the federal health care law was constitutional because the individual mandate provision and penalty can be construed as a tax. The controversial 5-4 majority decision was written by Chief Justice John Roberts in a surprise to many. The decision did, however, provide state flexibility in the Medicaid expansion of the new law. And with that background, we begin our roundtable discussion with Dr. Joe Thompson, the state's Surgeon General, who heads the Arkansas Center for Health Improvement, and Michael Stock, President and CEO of QualChoice, one of the largest health insurance providers in Arkansas. Thanks to both of you gentlemen for being here. Mike, I asked you, you said that there's obviously some problems with the law. What would you change to make this law better? Or if you could start from scratch, which some people have suggested should be done, what would you do to make healthcare better in America, things that the law is not doing right now?
One of the big problems we have with healthcare in this country is the basic economic model for how healthcare is purchased doesn't really work the way most other economic models work. In healthcare, we have a consumer, person A, who's getting services from a provider, person B, but someone else, person C, is paying for it. And so the true value relationship between the consumer and the provider isn't really understood as well because somebody else is paying for it. And that because of that, there are consumption and utilization problems in the country.
Joe, what would you do? What would you change that's not in the law today?
I'd put some of the same things that Mike's talking about, even in our Medicaid program, to have some minimal cost sharing so that individuals pay $1, $5, $10 for a visit, maybe even more to go to the emergency room. The other thing that I would try to align with is I think too often we're looking at short-term solutions. We need skin in the game for staying healthy and not needing health care in the future. We've got 10% of our state's adults that have type 2 diabetes directly related to obesity. We've got to have some incentives to have people not get those conditions that are going to be so costly over time.
Let's talk about what is in the federal law, still staying at the federal level here. There was some language in there that talks about Medicaid expansion. Kind of put it in layman's terms for me. What's your interpretation of what the states can do now?
Sure. Well, the federal government in the Affordable Care Act, through Congress's action, required all states to come up to a minimum level, 135% of the federal poverty level. Our state's at about 26% now, or $6,000 for a family of four. What the Supreme Court said is that the offer is still there, but that the federal government can't require states to do that.
And you've got some Republican legislators in Arkansas that are using that interpretation of the Medicaid expansion as a reason to not conform with the federal health care law. Do they have a valid argument?
Well, I think we have both Democrat and Republican leaders that are concerned about the federal fiscal budget, as well we should be. But the expansion of Medicaid is 100% paid for by the federal government for the first several years, and then it moves down to be a 90-10 match, where for every dime the state puts up, the feds put 90%. This is an enormous opportunity for the state to leverage its resources and to get care and access to financial insurance to 500,000 folks that have never had that opportunity.
Mike, how do you guys deal with the 500,000 folks that don't have insurance? How does that impact your company's approach to healthcare reform?
The biggest impact it's going to have on not only quality choice but other insurers in the state is how we'll get access to those people. It's going to be through some type of exchange that will be set up in the state, which the easiest way to explain it to the public is it's going to be like an Expedia.com for healthcare, where there'll be a website that you can go to and pick and choose among your insurance carriers. We'll be asked or have the option, do we want to offer our products in that exchange, and that's where people will go to get their coverage if they're going to be eligible for a subsidy from the federal government.
Do you support the healthcare exchanges? Do you think this is a good idea that we should be doing this regardless of healthcare reform?
Well, just the concept of an exchange, I mean, there are exchanges that exist in the country today, and we participate in private-run exchanges that are out there right now. So it's a good way to get access. It decreases the cost of distribution in delivering healthcare services to people. So we're not opposed to the concept of an exchange. The question is, to offer a product in exchange, you have to have a benefit plan that meets what the federal government calls essential health benefits. Those still aren't exactly known. They're being defined in this state. Every state has the option to define those independently. What will they be, and then what's it going to cost for those essential health benefits? It has to be something that people can afford.
Let's shift to what's happening here in the state of Arkansas, because the Medicaid situation that we're dealing with in the state of Arkansas is separate from the federal health care law. A lot of people have confused.
Okay. And it's not just Medicaid. Our private sector, the insurance premiums have doubled in the last 10 years. So both the public and the private are facing unsustainable rising costs. The way I look at this bundle payment is the payors are really trying to assign responsibility to a clinical quarterback who's responsible for an episode of care. Right now, every individual provider gets paid separately. There's no incentive to work together. And what the payers are doing is they're saying, we want a quarterback who not only is clinically responsible, but has some financial skin in the game for making the best outcomes happen.
And I've heard you, Mike, use the general contractor's example.
Correct. Well, the way healthcare is delivered today is on a fee-for-service basis. The problem with that is it can reward the people. Well, it does not reward people who really don't render care as efficiently as possible, and it doesn't give any incentives to get more efficient today. So a system like episodic payments can create more of a value proposition between the patient and the providers, so that there's a better understanding, and that the people who are paying for it in that economic model I described before really are paying for a value that's determined up front, and everyone agrees what's the outcome is going to be. We're really looking for defining outcomes up front and working towards an agreed upon outcome, rather than just paying for every touch that a provider has with a patient.
I hear from a lot of folks that are concerned with changing the status quo. Do you think that the healthcare community in general is ready for this transition?
Probably not, because it's going to require a lot of change in the way they've done things. No one likes change, no matter what it is. It creates uncertainty and that type of thing. But it does create an opportunity here for them to regain some reward down the road and improve their practices. And hopefully it should also then increase access, because we're going to have an access problem in this country.
Well, one more point on this too. Why did you guys jump on board with this enthusiastically?
We really did it because we believe that there is an opportunity to improve the value proposition between the consumer and the physicians and the providers, that there's just some inefficiency that exists in the system, and this is an opportunity to take some of that inefficiency out of the system, but allow the providers to do it and not have it be forced on them by the payers.
So I threw a lot of stuff at you in the last hour. What I really wanted to do is just practice using some of this terminology around health determinants, health disparities, market and social justice, and really give you a sense for how these perspectives and this vocabulary have shaped the health system that we have now and are continuing to shape our health system. I don't expect you to have memorized much in this presentation. I really just hope that it starts some discussion on Blackboard. So meet me back there and let me know what you thought about the presentation, handouts, or anything else that I gave you. Thanks.